So two things to do now. One is we're going to hear a bit, for those of you, you only went to one conversation, so here's a chance to sort of just hear the action points only, not a, well, we then discuss this, and then we discuss that, and then this, you know, the type of death by feedback type of, we're not doing that, we're doing key action points. And then I think, Adrian, there's an opportunity perhaps to have a further engagement with perhaps some of the issues that are of concern to people, sort of trying to bring together some of the learning that we've done, and then it will be time to go home, I think, after some final words from you and I. So we're going to hear a bit from the different groups. Who's going first? We're going to volunteer. Are these? We've got some slides, I think. Have we or not? We do. Population segmentation. That would be you. Yeah.
Can we just hop back?
Pop back one.
One. Oh, no, sorry. Okay. So do we have the action points on the slide? Hopefully we do. Wonderful. Yeah. So in our group, we talked about population segmentation. And that's the idea of really just trying to understand the population you've got. And there's lots of different approaches you can take. I mean, one of the key questions is, you know, in terms of bracketing people into different segments, exactly what labels, approaches do you use? The end goal, though, is to try and to group people in, or cluster people that have similar care needs, so you can best design services around them and their needs. So Vince Mack had some absolutely wonderful slides and some really interesting work on getting people, I think, from North West London to try and decide what the various segments should be. And I really recommend absolutely fantastic graphics, really interesting stuff about costs as well. But jumping to the action points, one of the things we looked at was the fact that the way segmentation can be used, it's all about really what you want to achieve. So the first thing is think about, you know, what do I want to get out of it? The second is to think about what the tools available to you are. And then population segmentation really just falls out of marrying those two things up. So one of the action points we thought about was maybe think about using segmentation models to identify low-value services. So this is very much from a point of view of cost containment and trying to use those segmentations both to identify where there's services that aren't getting the value that they should do and look at them where they can be changed, but also protecting services that do give high value. The example we looked at were drug and alcohol services, which have a very good evidence-based return on investment for the wider community, which is the second point. And there we're thinking about, of course, those financial models that make sure they adequately distribute the risk and reward amongst all the people that are participating in the early adopter. The third action point, which I'll jump onto quickly, is thinking about the tension between, do you go for a segmentation model that's standard across all of North West London, which has the advantage that, you know, it gives you a common language, everyone can talk about it and understand and interact, or should the early adopters design their own segmentation models, which might be much more tailored to their needs, much more specific, but again, possibly run the risk of creating their own silos. And I believe the actionable point about that is there's extra communication events between the early adopter programs so they can agree a plan of action together.
Two interesting things, just listening into that group that I just heard. One is not to get confused by the fact between the fact that the frail elderly have one of the highest costs per person, but in terms of population group, they're not the most expensive population group because there aren't so many of them. And we actually, it's often younger people who are driving a lot of your cost, but that's because of volume and numbers and mental health. And the second thing which I took away was we need to collect richer data because your statistic, which I've heard elsewhere, which is if you have a daughter, very specific, living within 7 miles?
7 miles.
7 miles, you're less likely to be readmitted to hospital. Not a son. Sons are useless, sons are hopeless, daughters. We could. What other information is lurking out there in some of this big data that we might get our hands on? We can ask Dennis. We can ask the NSA perhaps to send us some of that. We can put that into the models. So who's next? Next one. People development and culture change. Who's who?
That's my
Santiago.
group, yeah. Do not focus on activity-based incentive scheme. Well, that's. I was asked about things that shouldn't be done, and I shared with you that we made a mistake, and we established an exclusively activity-based incentive scheme, and it resulted in a complete failure, because the goals were not aligned with the goals of the company as a whole. So please don't do that. Communication at the communication is a very powerful tool, and you have to use it wisely. It has to be part of your strategic plan to implement change. And of course, one of the things that we have discussed about is that it is necessary to define clear communication paths and clear communication channels, and it is needed to structure the communication, okay? To arrange communication and to schedule meetings and to schedule actions. And then people are already delivering high quality services, so we need to find them. And this is important. When it comes to drive change, it doesn't necessarily mean that you have to turn things around. People are doing their job and doing their
build
job.
On. That's one of us. Might have been me. So build on what is good already,
Okay.
rather than
Okay.
destroying it all and building it again.
Exactly.
Yeah.
Don't destroy anything. Just try to identify small areas of improvement and try to build on those areas of improvement, and have people identifying those areas of improvement. Okay.
Great. Good. We've also had Dennis's rule of 8. One of the things that we see in other types of work of this sort is communication being built on some sort of narrative. You know, this sort of the Mrs. Smith, Esther in non-shopping, or perhaps more technocratically British Columbia and Oregon, the triple aim. You know, there's being some sort of story that you're communicating, rather than just the technical components of we're going to do risk stratification. But
in terms of being open and frank and frankly, including the patients and citizens in the process of change as well, of course. And well, you have professionals rotating from primary care to the hospital, and interchange of professionals from one PC center to the other, so they get to know each other.
So this hints at a theme we heard a lot about this morning, which is a lot of the problems that look like technical problems are often relationship and trust problems, right?
That's it.
Okay, great stuff. Thank you for that. Any comments from either of people who are in either of those two groups about those subjects that we think we've missed, actions that we thought, oh, they haven't mentioned that? Yeah, just hold on a sec. We'll. You can shout, but actually, you're probably in a very good acoustic place. Try shouting, and we'll.
It's really just to ask a little bit about the first point you made, which I won't shout now, which is on don't focus on activity-based incentive scheme. When you say it's a failure, what happened? The first point, do not focus on.
When you focused, when you were, what went wrong?
Incentive, it failed. Why? What happened?
Why? Because there was, I don't know if this is a very polite word in English, but that was kind of perverse.
Yes.
Okay.
We know that word. That's definitely very familiar to us.
So very nice change. Okay. Okay. When we got started, we wanted our doctors to to be able to perform as much as possible, because that was something that was good for the company. We wanted to eliminate the pre-existing waiting lists, and that was something profitable for the company. So we decided to embark in such an incentive scheme. But after that, you realize that if you are speaking of an integrated healthcare organization, you have to do what is needed to be done. That's it. More is not always better. Yeah. So if you start your company with this scheme and then you realize that it's not good for the company, the better you stop it, the sooner you stop it, the better. Otherwise, it's going to become culture, yeah, and you'll have a big problem.
Good. More is not always better. That's a good motto. On. Commissioning for and delivery of outcomes. Who is that?
That's me.
Okay.
Yes, you can see it got boiled down to maybe 4 categories. The second and third are somewhat similar, but here's what some of the observations were. One of the discussion was around the importance of defining on the spectrum of what your ambition would be. In other words, should you be working in a way that you have a well-defined group of patients that you're going to focus on, like the sickest or most expensive or those that hit the emergency room the most often, or around a condition like hip surgery, back surgery, or diabetes or whatever. So that's one end of the spectrum, focused, well-designed, well-defined population, versus making the big leap all the way to a large-scale capitated organization. And somewhere on that spectrum, each group needs to decide where they might best fit. And that was the first point that came out. The second, and in addition to that, whatever you decide, you have to have the outcomes defined that you want, so you can measure those outcomes. The second is the role of primary care in the system. And the system would include, as I take it, the hospital, other sources of delivery of care, like the ambulance service, like pharmacy, perhaps home health, that sort of thing, hospice. If you look at that whole system, has there been a good discussion about where the role of GPs ought to be or primary care ought to be? In other words, have you defined who the conductor of the orchestra is going to be, the accountable body? The third point is somewhat similar, and that is having a discussion around the centrality of GPs. If it is determined, I guess, that if GPs are going to be that conductor, I mean, somebody's got to stamp up and say we're going to be the conductor, then really the conductor becomes the key person that should be held responsible for the outcomes that you just said you'd want. Now, along with responsibility in traditional management thinking, if you're going to have them be held responsible, you also have to give authority and you have to give accountability. So they're accountable and they are responsible, and many organizations make them accountable, make groups, make somebody accountable, give them responsibility, but no authority to get anything done. And that's a prescription for real problems. Then the last point is that somehow link the tariffs to the outcomes you decided to aim for at the beginning of on the first list. So linking the tariffs, make them relevant to the outcomes.
Thank you, Dennis. Just a slightly tangential point, but while we've got you, interesting. If it's not GPs, there's been a fashion in a number of countries for appointing sort of care navigators, care coordinators. To what extent is that just putting another layer on an already broken, complex system, or is it something that you think has some value, perhaps for the most complex patients?
I think defining the responsible physician is well worth it. Because I picture that the patient is at the center, and the next round, right around them, the next rim.
Some of those people, of course, aren't physicians. They might be.
But really, ultimately, the responsibility. Yeah. The actual person who interacts could be a care coach, health coach. It could be a nurse, somebody else. But somebody has to have that responsibility. Now, is that in this country going to be GPs, or will it be specialists? What will it be? In the U.S., we have both models. We really do have both models. It's something for discussion, I think, in this country.
As I thought.
And it doesn't have to be one or the other. It just has to be clear.
But there must be responsibility. Jolly good. Anyone in that group who wants to make a comment or observation that Or anyone who wants a question on that? It's all very clear. There's a big agenda lurking underneath those simple words, I feel. I don't know about you. That's quite very clear. Thank you. Yeah, were you scratching your head or just waving? You are waving at me. You're not? Okay. You're holding the mic. Okay. The person next to you was scratching their head in that way that you do that and you find you bought an artwork. David, quickly, yeah.
Just one question for the North West London team, and that is, given what you've said about the fundamental importance that GPs play, what part is NHS England being drawn into in North West London to make sure that the GPs are not kept out of the fold, at least from a performance management point of view, and all the rest of the relationships that we have in our broken system?
Okay, so I think just to log that comment, log that thought, because it's an important one. I don't know who's recording this. Amy, perhaps someone could, because that is a key. We've got no one here to answer that question, I guess, have we? But we'll just log it as a really key one. Let's move on. Integrating information systems. Jackie.
That's me. Yeah, just a really, really interesting, lively discussion, which kind of started before this afternoon. First of all, congratulations to North West London for putting all the energy and effort into having an information strategy that sits alongside investing in integrated care. As I think has been demonstrated by this morning's presentations from the two gentlemen sitting either side of me, it is a hugely important component. It's an enabler, it's critical to the success, and it should be near or on the top of everybody's list to get this right. We had lots of discussions about this, and the actions that we came out with were that the first thing we need to do is make sure the information strategy really does support the purpose of delivering better outcomes and isn't just geared towards how you enable the technology, and that this is effectively communicated as part of the strategy. One of the things we talked about a lot was the importance of information in the context of the workflow, in the context of the clinical decision being made. So yes, it's important to have capabilities around reporting on pricing and reimbursement and incentives and activity, but the most important thing from an information system is that the clinician has the information that he or she needs and the patient has the information that he or she needs at the point at which a decision is being made about their care. Everything else will follow from that. Rising out of that, there was a view that the second action would be to start identifying some top clinical pathways to look at first. So once you've found a technological solution, and believe me, there are loads out there, once you've found a technological solution to joining up the systems, to getting electronic health records to become a reality, find some clinical pathways to really roll it out so that you can develop the sorts of standards that we were talking about this morning. It's not going to happen overnight. It will take years and you will never finish it, but have a clear roadmap with some high priorities to get you going. The third action, go and have a look at what's going on elsewhere. We are terrible at this in the NHS. We always think we're the first to invent anything and that we're really, really different to any other healthcare system, and it's just nonsense in this context. Go and have a look at some of the systems that are in use here and in other parts of the world and in other hospital systems. They're really good. They're relatively straightforward to implement compared to our massive investment in Connecting for Health. And it's all doable. And then the last point, we had a fourth one, hope you don't mind, Nigel, and that was there was a general consensus that we ought to be quite patient about this and have an incremental and iterative approach. If we try and do everything all at once and we try and design it as a big bang solution, it will probably be obsolete by the time we've written it, and it will certainly be obsolete by the time we've implemented it. So let's try and go on this journey in an iterative, agile way and be patient, and we'll get there.
Does that relate to the point that it's what Ian was just discussing about being incremental and iterative probably does seem to be the way forward for these systems, but having a standard set of data definitions and interoperability standards at least?
I don't agree. You need semantic integration if you've got systems talking to each other. Beyond that, you don't need that much more. But for semantic integration, you will never have 100%. And none of the best systems in the world have 100% semantic integration.
Well, it doesn't need to be 100%, but there is a danger, is there not, of different people within the area starting. I mean, you can create additional diversity was the question I was
You
asking
can,
about
but
whether
the
there was
worst case, I mean, some of the I mean, we have debated this probably not on this stage, but the worst case with the cheapest portal systems is you just get an incredibly long list of meds,
Yes.
which you have to look on page 16 before you find the one that the patients are critically allergic to. But sorting that kind of semantic integration out is not that tricky these days. And there are there's lots of work already been done, and if you buy something off the shelf, it will come with a standard semantic
I was
dictionary.
less worried about the semantics and just at a rather more basic level than that, about whether how you get everybody aligned, you know, how you get all the data
Again,
sets
I don't
aligned.
think I know of one, even some of the biggest systems, I don't know about the Mayo, I have to say, whether your systems are all joined up everywhere, but I very much doubt
They don't
if
need to be all
everybody
joined up
you
at every
interact
point, do they?
with
They need
is...
to be joined up on the critical information that you need to feed your business systems for secondary use. But
I think
yeah.
the key is pragmatism,
Yeah.
really.
Yeah.
So you don't go for that big bang system, because we know a lot of them just, they
Don't-
incubate
they go
forever
bang,
and don't
yeah,
happen.
yeah.
It's about joining stuff together where you can, improving it where you can, and for the stuff that's more troublesome, then you take your time to improve it and join it in when it's ready.
And I would argue strongly that the business analytics comes from getting the AHR right. And if you look at any of the readiness assessment tools that are around for ACOs, for example, they start with EHR. You don't try and be one unless you've got an EHR. So pragmatic, but realistic.
yeah, good, excellent. Let's move on. Oh, anything to add? Yes, there's someone here. Yeah.
Hi, there's actually quite a lot of talk about pathways, and whilst I agree that it's important to have the pathways there, I believe that patient records should be complete, not just what is wrong with them in a particular, they shouldn't be categorized that much. There should be a complete record, and you should be able to then just query a pathway, or you should query what is their latest meds. There should be simple buttons that you can press and query, and there should be a summary sheet at the front of every patient that is a query that automatically comes up. So the minute you walk into a surgery or a hospital, it has your basic information, any problems that you have at the moment, and your medications, and your basic history, and also whether you have a disability or a hearing impairment, and that should be on the front page so a doctor can have a sum up immediately they walk in, just a summary page, and then the rest they can look at the entire thing if they want. They can pull up blood tests, they can pull up anything, but it should be very simple and all query based.
Might want the care plan if that's available.
Well, the care plan as well.
Yeah, I mean, I have seen, many examples of that kind of query-based system where you have a front sheet with a high-level information, and then you drill down to where you want to go. I've also seen, to be honest, much better systems where, you're making a decision to prescribe a particular med, and you log on the system, and it pops up and says, please don't prescribe that because this patient's allergic to it. That is real information, and usable information in the context of the workflow. So that's what I would encourage you to look at.
So the link to the workflow, I think, is a key thing, which you've mentioned a couple of times. It wasn't on your slide.
No.
But let's assume it was, because it seems like an important point. Okay.
It wasn't an action.
Well, it could be turned into one.
It can be turned into one.
Okay, good.
Can I ask another one?
Yeah, go on.
Kingston, patient leader from Clark. Just to say, have you thought about us having ownership of our own records? I think if we have our own records, and also if we have our medication passport, actually we could pop up and tell you what we're allergic to. Have you thought about that? There's a brilliant GP surgery called HTMC with very deprived population, where a quarter of patients have their own records, and they've shown reduced presentations.
I'm a huge, as some in the room will testify, I'm a massive campaigner of patients' involvement in their own care, self-care management, information co-production, whatever jargon you want to put around it, and have championed it for a long time. And part of that is actually having ready access to information, a good interaction with the system in terms of booking appointments, getting test results, communicating with your physician without having to actually go and sit next to him and take time off work and all that kind of stuff. That notwithstanding, I think the whole issue about patients' access to their records needs a different approach, and it needs a dedicated look at what's really relevant to the patients. There are some histories of real failures here. So Google Health, who withdrew from the market completely, it was a real disaster for them, and it was testament for how really not to try and do this. Sorry, I'm not going to be quoted on this, but there are some other really good examples. I'm not sure what the Mayo has or indeed the Spanish system. I'm not sure what they have in terms of interactions with patients, but if you look, for example, at Kaiser, you can log on as a patient at Kaiser and you get relevant information for you at the level of access you need, and that's great.
I think most big organizations
Most big do, yeah.
Mm-hmm.
Okay, good.
But it needs a different look, doesn't it?
Onward.
That's the thing. It's not the same as the clinical look.
That project probably isn't an action yet then, is it? The patient bit?
I think the first thing is to get the information.
Actually get some information
Yeah,
that you
that'll
can
be
get
nice.
first. Good. Co-designing with people. Who is this?
Right.
Yeah.
Right. Communication, that's the first thing. It's always a good thing. Build a case for change with users and staff. I'm seeing communication here as an organisational communication, and that's Dennis's points this morning about the power of 8 and the root of the number of people in the organisation. The other thing is we talk about co-design, but actually there's a co-research, there's a co-defining the brief, there's a co-designing thing, there's a co-prototyping, and there's a co-evaluation. So we really need to be involving all the stakeholders, that's clinicians, admin people, patients, and designers. You know, if you're solving a problem, design is what, I argued that design is what solves problems. It looks at problems and comes up with solutions. So designers are pretty good to put into the mix because they're naive, you know, they're personable, they can talk to people, and they're focused on problems and solutions. Simulation. We're saying here, spend some time wargaming service change to iterate towards a new service model. I quoted the thing of a picture being worth 1,000 words and a mock-up or prototype being worth 1,000 pictures. Really, really useful to prototype, to simulate early in your process so that you, it's an American thing, you know, let's see what's wrong with it quickly, you know, let's just find out what doesn't work quickly. So putting that process of prototyping and testing into action as early as you can in the process is a very good principle. Interdisciplinary working, well, architects, this point was raised that there are people outside of the health service who have something really valuable to offer, artists, architects, designers. Involving these people can inspire change. I mean, one thing that's very important in, we talked about the double diamond, which is something you can look up. It's promoted by the Design Council, proposed in 2005. It's a double diamond model, opening things out, closing them down to define what you're going to do, then opening out for creative solutions, and then closing down to deliver. The first stage is researching and discovering, and immersive research is needed. And I argue that that needs to be by an outsider, because staff, you know, they've been there a long time possibly, they know it all, they probably take it for granted. They just assume that's the way things are, and they may well be stuck, so naive is good. That would be the end of mine.
Super. Thank you very much. Any comments from people in that group? Anything missing? Admirable summary? Yeah? The microphone people haven't slowed down, they're still whizzing along. Yeah.
We also discussed how professionals are very often just not used to working with other people to co-design services, and they themselves may be quite inhibited to do that. So there's a stage where people need to become comfortable with that in a gentle kind of environment. And by fortuitous chance, the Integrated Care Pilot has created those groupings over the last couple of years called the MDG groups. So around 40 of these groupings of around 50,000 population exist in West London.
Mm-hmm.
Surely a neat trick would be focus on the people who've developed the trusted relationships in those areas and say, hey, you, here's a small amount of money, how about a bit of co-design? We'll show you how to do it, we'll hold your hand.
Okay, that's a great suggestion. Thanks very much. Good. Someone is recording this stuff, aren't they? So this isn't just dripping away into the earth. Is that Adrian's right? Adrian is writing, so that's a good sign. Excellent. Okay, thank you very much. Onward. Adrian, this by process of elimination.
Unless there is any more
this must be you.
discussional points to be made, Nigel.
Well, I think, there's been a lot of material today, and I guess there's an opportunity. We've got some of our experts still here. Are there questions and issues that you think we should have talked about or haven't? Are there things which are unresolved that you think, oh, we still need to talk about that? There's definitely, a hand went up very quickly there. So I just think we just have an opportunity to just collect some of that together. Yes, sir.
Maurice Hoffman.
For us,
one comment.
Would you say who you are for us, please?
I'm just a patient and lay person.
No, you're not just a patient. You presumably
I am an NHS patient. I'm a lay person involved in research.
Okay.
And other activities in London.
We'll allow you to remain anonymous.
But we've heard nothing at all about mental health today, and nothing from anybody, none of the models talk about it. Secondly, it will be helpful, certainly for patients and voluntary organisations, that in each borough there should be one person we can turn to on this project, because at the moment it's a blank. So that's one comment, but could we have some feedback or thoughts about mental health?
Okay, that's a great point. Mental health certainly came up in the group where we were talking about how you segment and think about patients. It's sort of been implicit in some of the other bits of the conversation, but it hasn't received perhaps the attention that it might. Anyone want to comment on the sort of mental health components of this? Adrian?
I mean, I'll just make a comment on that. And of course, it's an absolutely important point, and mental health is one of the biggest causes of morbidity and mortality in the population. I have to say, nor have we particularly talked about cancer today or musculoskeletal disorders. I think we've been talking at a general level about how we approach the problems that face the population. And I think a lot of the principles we've discussed could just as well be applied to one section of population or one disease or condition as another. I think it's really important we don't forget any of the condition groups that we talk about, but the point.
I guess the difference with mental health is it has to some extent been carved out by specialist organisations that have to some extent taken some of those people away from the rest of the system in a way that isn't the case with musculoskeletal, for example.
And I think in a way that's the problem. So mental health almost becomes a Cinderella, if you like, in the system, when actually it's a Goliath of a problem.
Yes.
And the problem with mental health is when you see it confined to mental health care providers, when actually we know that the physical illness amongst people with mental illness and the implications for their physical illness of people who have comorbid mental health problems is massive.
So perhaps we should be stripping out the low end of mental health out of the mental health trust.
It should not be a specialist area, absolutely.
Jackie.
Yeah, I was just going to say, I mean, as you say, Adrian, this wasn't really about any particular group, and we didn't focus on any one in particular, but mental health did come up in our discussion quite a lot because of the issue around data sharing and consents and ethics in relation to the governance around data. And we were talking about the difficulties of patients not wishing their mental health status to be shared with their heart surgeon, for example, and whether or not you could overcome some of that by allowing sharing of medication information, for example, which can be crucial in terms of outcomes. So we did go into it in some detail because it does present a slightly different, as you say, Nigel, a slightly different set of issues which require a little bit of a special attention.
But I think the challenge about whether the actual delivery model we've got is the right one is a very interesting one. That, I've just remembered I'm doing a piece of work for the London Mental Health Chief Executives, and I don't think they've entirely paid their invoice. So we could just keep my last comments to yourselves just for the next week or two. I'd be very grateful. I think yes, you are waving at me. Yeah. So the light's in my eyes. Say who you are for me, please.
Amrit Satcher, Liaison Psychiatry Consultant, and thank you for bringing up the point. I think you're right, Adrian, that yes, other areas haven't been discussed, but I think by virtue of the fact that mental health is a Cinderella specialty, it needs to be a cross-cutting theme, but I think it actually needs to be mentioned. So our learning from the ICP has been that mental health was brought in really late. We had to kind of force our ways into the programme to get involved in the care pathways, and then I'm boring myself by quoting my own data over and over again, but some of the stuff that we've done through sitting in the MDGs, 200 patients discussed, 81% of them for diabetes had something to do with mental health, and only 41% were they brought up as a mental health case. So I think there's an issue of not being detected unless the mental health physician is in the room. So there's something about us being able to, being a core part of the thing. So, and I'm just a bit worried that we've done all this learning with mental health over the last 3 years with ICP, and it seems to have got lost again. So I want to make sure it does get into the centre of things.
Is Adrian writing at this point?
No, absolutely, yes.
Yeah, okay.
Well
I'm just
noted.
checking that you were... that sounds like a one that doesn't fall through the cracks again. Okay. This is probably one, of course, where we do want to kind of multi-skilled professionals completely rather. I mean, I think this is the point I was kind of making, not very well, was the danger of mental health being in this silo actually has been to its disadvantage, I think, in many ways. It's a Cinderella that's taken itself to the kitchen, in some senses, and is rather enjoying sitting there feeling left out. I really am not going to get paid. Let's move on. Okay. Any other comments or questions? Yes. Say who you are for us.
Oh, Carol Bell. I'm a Children's Commissioner, Health Commissioner, but Joint Commissioning. I'd just like to say, if we were trying to fill up some of the gaps, we thank you to Dennis for mentioning children on several occasions during his talk, but actually children need to be considered within a whole systems approach. We have got a model that we've developed. It is similar to some of the work that's happening for older people. And I'm just expecting that all of the ways in which people have thought about whole systems for adults can be applied when we come to think about the children's model. But connecting care for children is damn good, and we ought to use it.
Good.
Okay, thank you.
Good. I hope we're just not going to work our way through the ICD-10 code book here and things that we failed to talk about, but that's both points very well made, I think. Panel, any sort of final thoughts? Dennis?
Yeah, I'd just like to make a comment, too, about this idea of mental health of certain conditions. I agree that that's a very important point, but the fact that it is a very important point underscores one of the problems with people not understanding what integrated and coordinated care is about. Let's use a different topic. Let's use cancer. In the United States, if a patient with cancer goes and sees a surgeon, they're most likely to get surgery. If they go to see an oncologist, they're most likely to get oncologic therapy. If they go to see a radiation therapist, they're most likely to get radiation therapy. Who is the coordinator, the responsible person, to direct what services are needed for that individual? And that's what I meant. Is that a GP? Is that a coordinating physician? Who is that? And the same goes with mental health. We have some programs in Tucson we're working on, and in the US we make it worse because mental health is a carve-out payment. And in fact, if you're managing people with medical conditions, it is very rare that they even communicate. Who's the coordinating physician? Who is the person that is responsible for that? I think if we can really tackle that question, our country, your country, I guess, and it isn't just one specialty. You can maybe draw this along many different lines because we really need to start thinking about the whole health of the person, the coordinating person. I've had neurologists stand up and say to me that, oh, we're the primary care doctor for their Alzheimer's. And I said, really? Do you give them their vaccines? Do you take care of them when they're going to China and make sure they don't get their pneumonias while they're there? Are you available 24 hours a day? That's another story. And they think they were the primary care doctor when they weren't. They were behaving, they thought they were for their one condition, but they weren't taking care of the patient. So the underscores this need to have a very honest conversation about what does coordinated and integrated care really mean and who's responsible.
Thank you. Yeah, great point. And I think a big challenge, well, we can see that being the GP for quite a lot of patients, there will be a cohort of patients for whom that's probably too big a challenge. You need some special, you may need some carve out or some other special provision.
But that's what the conductor of the orchestra does. When you're playing a piece of music, there are certain times when the timpani has to do their job, but the conductor says, that's it. So the conductor orchestrates it. The conductor doesn't give the care per se or make the music. They are conducting the orchestra of care for the patient. And that's where this primary care doctor or coordinating physician or GP, whatever you want to call them, has to take that authority, responsibility, and accountability.
Great, good. Other comments, thoughts, questions? David, quick.
Yeah, just following on your comment there, Dennis. I think in this country, the divide between health and social care would offer a suggestion that potentially, unless there's a dramatic change, the GP is not the right person, because a significant part of the care provision within the care plan needs to be outside of traditional NHS healthcare. A significant amount of that is about how is that person enabled to live an independent, fulfilled life in the community. And GPs don't tend, I would suspect, with the amount of pressure and workload they're under at the moment, that they wouldn't want to see a significant influx of additional workload around the community aspects and the caring aspects. So it does beg the challenge of whether we've got a true, fully holistic coordination in mind for the future.
But so Staffordshire are putting micro-commissioning of adult social care with groups of GP practices who can then have a specialist who the GP says, who that function is delegated to. And, so I mean, the point is someone responsible. I think you're making a simpler point, really, Dennis, as I understand
well,
it.
Well, I was trying to make a simple point, but remember, I agree with what you just said. Many organizations that are taking this as an organizational responsibility are creating teams who are focused on a patient. And that team may be a different team for each different patient, but they're all the same folks. And many times, the key person is the health coach who is interacting. And at times, the health coach says, hey, they need to come and see you, Mr. or Mrs. GP, or they need to see the psychiatrist or whatever. However, over all of that is a responsible person who's conducting that orchestra. So this is a debate we have to have in the US and you have to have here. But what I'm assuring you is within the US, those organizations that are taking accountability and especially have their own insurance company already, those organizations, they have crossed this bridge and they're doing it that way. There's somebody over coordinating the whole thing.
Great. Thank you, Dennis. Adrian.
Thanks, Nigel. Well, thanks very much. We're going to call a close in the next little while. I'm going to just say a couple of words, and Nigel. I'm not in any way going to attempt to draw summary lessons out of what's been a very rich discussion. One thing I did learn was, and I thought to myself, if we listen to Dennis and we count the things that he says 8 times, they're probably the things he's trying to get across. And I think I've heard him say conducting the orchestra at least 6. So at some point, I'll think it was my idea and I'll go away with it as the lesson I'm taking from that. But the communication's at the heart of all of this. This has been a terrific day. A number of people come up and said how much they've enjoyed the conversation today. We were, of course, bedeviled by the strike, but you nonetheless have braved the efforts of the strike and have got here, and I'm grateful and appreciative of that. There is huge energy. I think that demonstrates there's huge energy and interest in this whole programme across North West London, and I think that Daniel Thurza and others have done a terrific job in creating that, and a number of you have played a big role in that as well. And I think today's discussion demonstrates that. We are reaching a turning point, a next stage, if you like, in that process. as we start to consider the early adopters, piloting some of the principles, and where we go from here. But one of the things that has struck me, and it's come through the day as well, is the huge ambition there is in all of this. The huge ambition that's been set out for whole system integration across health and social care, across North West London. And several of the points came through about the need to localise that, the need to identify the local leadership, and actually they need to get into some of the detail, the nitty-gritty that will make that grand concept work. And whether that's on the integrated information system, the electronic patient record, the details of contracting, whatever it is, there is a lot of hard graft to be done to make this real. And that is why I think that time and again we've heard this takes a lot of time to develop in any system. So that's ahead of us. But I've got no doubt that as a whole, North West London, if you took any area of the country, the level of the debate, the level of commitment, the level of interest is second to none, and it really is exciting to be part of that. There are some people to thank for today. There's been a huge amount of work gone into this. Amy Darlington has masterminded all of this and has been really well supported by a team, particularly of Jude, Lisa, Nuria, and Natalie. So I think we should express our thanks to Amy and the team for a terrific day. And thanks also to particularly our international speakers. And in fact, I think some people coming from Harrow have had rather more difficult a journey, though, than from Arizona. But nonetheless, Dennis, Santi, and Mercedes, where's Mercedes, who have come to share the benefit of their experience with us. That's been terrific. But also speakers from across the UK, and Nigel for chairing us through so ably. So again, thank you very much for all of you and for sharing the thoughts in the way that you have. It's been terrific. So Nigel's going to wrap up for us, but I thank you for your attendance, all your contribution. It's been a rich debate. We have recorded it. We'll take away the messages. There is a Twitter stream going on, and there will be slides on the website and other ways of accessing the information. So thanks again to all of you for your contribution, and back to Nigel.
Yeah, I wasn't going to sum up, but yeah, we're done. Thank you very much.
We're done.
Have a good journey back home.
Godspeed.
Fill in your evaluation forms.
Yes.
Yeah. Let's just do that now. Before you get up, have you filled in your evaluation form? You. I'm looking at you. Yes, you. Fill it in. Very good.